Good afternoon and welcome to our Neuroscience lecture series. I am Dr. Galit Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you'll have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of introducing Dr. Moises Lustgarten. His presentation is titled Dorsal Root Ganglion Stimulation in the Treatment of Intractable Neuropathic Pain. Dr. Moises Lustgarten is a board-certified pain management specialist and the director of pain management at Baptist Health Miami Neuroscience Institute. Dr. Lustgarten received his medical training at Central University of Venezuela in Caracas, Venezuela. He completed his residency in anesthesiology at the University of Miami-Jackson Memorial Hospital in Miami, Florida, followed by a pain management fellowship at Emory University Hospital in Atlanta, Georgia. Dr. Lustgarten approaches the patient care is, in essence, to listen to the patient so he can understand their need and recommend the best treatment approach for their health and lifestyle needs. His goal is to provide pain relief while allowing patients to perform their activities of daily living with minimal limitations. Dr. Lustgarten joined Miami Neuroscience Institute from the Center for Pain Management of South Florida, where he served as a medical director. As a founder of the center, he helped develop the facility that provides care to thousands of inpatient and outpatients with severe chronic pain. He has presented on pain management techniques at many professional conferences and is a member of the American Society of Anesthesiologists, American Academy of Pain Medicine, American Academy of Interventional Pain Physicians, Florida Society of Anesthesiologists, and the Florida Society of Interventional Pain Physicians. Please let's give a warm welcome to Dr. Moises Lustgarten. Dr. Lustgarten, what a pleasure having you. Thank you so much for accepting our invitation. The floor is yours.
Thank you very much for having me and everybody for joining this presentation.
You may go ahead and share your screen, Doctor.
Very good.
Perfect. Thank you.
We're going to talk today about dorsal root ganglion stimulation in the treatment of intractable neuropathic pain. Very long title. Most of you might be aware of the use of a technique called spinal cord stimulation, which is something that we do quite often in the management of chronic intractable pain. This is a special type of spinal cord stimulation device. By disclosures, I do not have a financial relationship with any company, and I will not discuss any off-label or unapproved use of this device. As a side note, the only DRG stimulator currently available is made by a company named Abbott. Again, I don't have a financial relationship with Abbott Pharmaceuticals. Our objectives today will be recognize the benefits of targeting neuropathic pain relief at the dorsal root ganglion. We're going to examine some literature regarding dorsal root ganglion stimulation in the treatment of intractable neuropathic pain. What are the indications of this device? This system is indicated as spinal column stimulator via the epidural and intraspinal lead access to the dorsal root ganglion to aid in the management of moderate to severe chronic intractable pain in the lower limbs in adults with complex regional pain syndrome types 1 and type 2. In the United States, right now, it is FDA approved only for the management of lower limb pain. But as you will see, it has many applications and hopefully it will get FDA approval for other regions of the body. For those of you that are not aware of what spinal column stimulation is, it's a device that consists of a lead that it's implanted in the epidural space in close proximity to the spinal cord that it's connected to a pulse generator or battery that delivers electric stimulation into the spinal cord. And via this mechanism, we're able to inhibit pain transmission from different parts of the body and help our chronic pain patients. Trying to define a little bit further, we have CRPS, which means chronic regional pain syndrome. It was formerly known as reflex sympathetic dystrophy. I'm sure many of the people joining this conference still use the term RSD as reflex sympathetic dystrophy. It is not used anymore. Now it's complex regional pain syndrome, and it's divided in two types. Chronic regional pain syndrome type 1 is extreme pain, which is usually out of proportion to the regional injury, and patients present with evidence of allodynia and hyperalgesia. Allodynia means extreme perception of pain to a non-painful stimuli, and hyperalgesia, it's an exaggerated response to a painful stimuli. And then complex regional pain syndrome types 2, or causalgia. It's a painful condition that arises specifically from damage to a nerve or a group of nerves. So the main difference is in causalgia, we do have evidence of damage to a nerve or group of nerves, versus complex regional pain syndrome, we sometimes can't even find the original injury on these patients. As an example of causalgia, you'll have, for example, ilioinguinal neuralgia after hernia repair. So causalgia is pain as a result of a nerve injury, typical a peripheral injury. And we also have a definition of persistent chronic post-surgical pain, which is that pain that persists for at least a few months, after surgery, but that it's clearly different from the preoperative pain, and it's not caused by other conditions such as malignancy or chronic infection. The neuropathic component is always caused by lesion or disease of the somatosensory system. What's the incidence of post-surgical causalgia? It's way more common than most people think. Chronic post-surgical pain incidence after hernia surgery is about 8.5%. After total knee replacement, it's about 15%. Total hip replacement, 6%. Foot and ankle surgery, 5.3%. After hysterectomy, up to 50% of patients can develop chronic post-surgical pain. C-sections about 10%, and lower extremity amputations is quite frequent. Between 30 to 85% of the patients develop post-surgical causalgia or post-surgical pain syndrome. So these are some examples of peripheral nerve injury where this DRG therapy has been proven to be effective. You have neuropathic foot pain. Patients present with severe burning, stinging pain that could be isolated to the toes, involve the whole foot or the lower leg. And it's very common in amputation of lower extremities. Hip, knee, or knee pain after arthroplasty that results to damage the different nerves in the ankle, knee, or hip. It is quite prevalent after total knee replacement. In some patients, you can develop post-arthroscopy pain, and these patients can develop significant pain post-arthroscopic knee procedures. We have post-hernia pain. When there is hernia repair surgeries, there could be damage to two major peripheral nerves, the ilioinguinal or genitofemoral. And when these nerves are damaged, we call it ilioinguinal neuralgia or genitofemoral neuralgia. We also have the chronic pelvic pain, which is more prevalent in females, but it could be quite common in males as well, specifically after treatment for prostate cancer, including radiation therapy. So this is an example of the approved use for this device that we have right now, which is mainly lower body. But like I said at the beginning, it hopefully will be approved for upper body therapy as well in the very near future. So what's the benefit of using dorsal root ganglion stimulation versus regular spinal cord stimulation? As you can see in the image on the right, the dorsal root ganglia, it's a collection of bipolar cell bodies of neurons surrounded by glial cells and the axons of the DRG sensory cells that form the primary afferent sensory nerve. It's very easy to identify, it's very reliable, its location is very reliable on almost every person. It's very easy to access via the epidural space. Therefore, it makes it a very good target for neuromodulator. It is surrounded by very little amount of cerebrospinal fluid, which allows us to put these devices in close proximity and therefore requires much less electric stimulation when compared to conventional spinal cord stimulation that goes just in the middle of the spine in the spinal cord, which is surrounded by fatty tissue and significant amounts of cerebrospinal fluid that might diffuse the electrical current. And then at the dorsal root ganglia, we have separation of sensory and motor nerve fibers, which will prevent unintentional stimulation of motor fibers on our patients. We have evidence that suggests that pain signals arising from peripheral injuries originate in the DRG. In animal models, patients that present with a spinal nerve neuroma, when you resect the neuroma, these patients remain symptomatic and pain persists. But once you resect the dorsal root ganglion, this electric activity disappears, which indicates that the dorsal root ganglion is the center of command where all this sensory input is generated and transmitted to the brain. So why specifically target the DRG? If you see the image on the right, the first individual has pain on his foot. When we use regular spinal cord stimulation, we're able to stimulate a large area of a body. You cannot specifically select an area. So you can place your spinal cord stimulator lead in a specific location within the spinal cord, but you will get electric stimulation, for example, from the waist down towards the right leg, or from the waist down towards both legs, or towards either leg that we need. When we target the dorsal root ganglion, you can direct your stimulation to a specific location. On the image on the left, you can see that each dorsal root ganglion will target a specific dermatome distribution. L5 will cover your foot and ankle. L4 will cover the lateral knee, lower leg, and ankle. L2 will involve the hip, waist, etc. So as we said before, the DRG is the control center for peripheral sensory nerves. The amplification of incoming peripheral signals can lead to neuropathic pain. If you modulate the electrical activity at the DRG level, you can reduce that amplification and therefore reduce pain perception on our patients. So you might be wondering, how do we place these devices? So basically, we have a needle/introducer that it's placed percutaneously, no need to incision, through the skin, just like doing an epidural injection on a patient. You go into the epidural space via a paramedian approach. And then through this introducer needle, you will advance a lead straight into the dorsal root ganglia at that level. Once you confirm the lead position with fluoroscopy, you're able to remove the needle and keep that lead or electrode in place in direct contact with the dorsal root ganglia. So once you have precise placement of this lead alongside the DRG, you'll be able to stimulate with very minimal amounts of energy that would only target the sensory fibers and not motor fibers. This is how the device looks. There is some words that are blocked on this presentation because I'm not supposed to use brands here, but like I said at the beginning, this is the only brand available. So on your right, you're going to see the pulse generator and battery, which is exactly like a regular pacemaker that goes implanted in the patient's body under the skin. And then the patients will have a device like an iPhone in which they can control the stimulation. So they're able to turn it on and turn it off and use different programs of stimulation according to their needs. We have evidence of multiple studies showing the significant decrease in pain scores on our patients by using this technique. So using a very large number of patients and as an average starting point of a VAS score of 8 or 80, and the final VAS score went down to 2. For those of you not familiar, VAS is the visual score that we use to assess pain from 0 to 10, 0 being no pain, and 10 being the worst pain they've ever had. So we've seen reduction from an average of 8 to an average of 2. There has been multiple prospective randomized controlled clinical trials that assess and compare DRG stimulation versus regular spinal cord stimulation. And we can see that there is significant benefits to our patients when you compare both. The studies have shown that you can reduce pain an average of 81% at 12 months, persistent relief to patients of about 86% of patients at 12 months, and significant decrease of pain, 8 out of 10 patients at 12 months. When you deal with chronic pain, it's not the way you assess success in pain management is not based on a score, it's based on functionality. So patients that are in severe pain, they might say, you know, my pain is a 2, which would lead you to believe they don't have a lot of pain. But then when you dig deeper into it, and you realize, you know, the patients can work, they can go out with their spouses, they can do what they prefer to do. So we assess pain based on function. If the pain is an 8, but they're able to do all they want to do with their life, that's success pain relief. So you can see here how the mean scores change when you use spinal cord stimulation on these patients. This is DRG stimulation compared to all the other types of nerve stimulation that we have, and it shows way superior improvement in our patients versus regular spinal cord stimulation, nerve root stimulation. And there is an interesting study done retrospectively on 21 patients that had DRG stimulation, and it showed a significant decline on opioid use. Again, as a background, patients with chronic neuropathic pain This pain is usually very intense. You know, most patients will describe it as terrible. And many of these patients will be on medium to high doses of opioids on a long-term basis. Once you use spinal cord stimulation and DRG stimulation, the studies have shown that close to 100% of the patients at 36 months have decreased their morphine equivalent milligrams from 144 milligrams to 3 milliequivalents of morphine, which is quite significant and should be the goal of every pain provider. When we use regular spinal cord stimulation, right now it's basically limited to failed back surgery syndrome patients, people that have had back surgery and failed, or chronic low back pain. Now with the use of dorsal root ganglion stimulation, we add a significant pool of patients into our effective therapeutics. And as mentioned before, we can include post-hernia repair patients, knee and hip surgery patients, foot and ankle surgery patients, pelvic floor pain, and lower extremity amputations. This is a kind of a guideline that we have that we use to identify the specific dermatomes and the areas that we want to cover. So just to give you an example, patients with perineal pain, we can target the S2 and S3. If a patient has thigh pain, we can target the dorsal root ganglion L2, L3, and so forth. In summary, this is the only FDA-approved DRG technology. It uses a specific delivery mechanism in which you're able to navigate this lead towards the target dorsal root ganglion, and you can obtain excellent and long-lasting relief and outcome to our patients. This is the references, and I will be happy to provide to all of you at the end. And thank you for the opportunity to speak to you guys.
Thank you very much, Dr. Lustgarten. There are a couple of questions that you can hear me well, right?
I can hear you perfectly.
Perfectly. Doctor, before we answer, we have a question from Belize in the chat room, but you mentioned something extremely important. Specifically, it is important to also delineate what the pain management specialist does. There is this idea that the pain management will inject consistently some kind of quote unquote, and air quotes simply because it is what I have to paraphrase. And they inject anesthesia just to relieve pain. And now, obviously, with this technique, you are sharing with us that almost 98 to 100% of the time, these people are actually leaving the opioid treatments in order for them to feel that they're not under the opioids consistently and improve their lives. Now, when do you, as a specialist, determine that an injection is best suited versus a device implanted similar to the DRG simulator?
Well, typically, this is not your first choice. So when you see a new patient with these type of problems, after you do your assessment, you have different tools that go from least invasive to more invasive. The least invasive will be, you're going to try some medications, not necessarily opioids. We have different medications like neuromodulating medications like gabapentin, pregabalin, some antidepressants, you have anti-inflammatories. You use different medications to manage it. You can use physical therapy, and then you can go do what we call interventional pain modalities. There's different types of injections that you can do to at least get temporary relief of the symptoms by blocking different nerves or nervous system locations. And then after that, you might go with stronger medications. You use this as the last resort. So when the patients are not responding to any of these therapeutics, or they have side effects from the medications that don't respond to nerve blocks, it's when you will consider this therapy. It's usually not a first
not a
line of
first
therapy.
choice in line of treatment. And you did list and you did specify that in your DRG grouping of conditions where pain is persistent and the chronic pain is persistent. Obviously, now you clarified that this is definitely almost like a last resort. Would any of these conditions be resolved at any given point by surgery, or is this something that the patient has to definitely continue to use for a long period of time?
Well, it depends on the condition.
Sure.
Obviously, for us, if the condition has a surgical treatment, then the patient is not a candidate for spinal cord stimulation. And we're not going to implant a patient where we know there is a solution that could be achieved surgically. And unfortunately, most of these patients have the pain as a result of prior surgery. And this is damage to some peripheral nerves that occur during surgery, that there is no surgery that's going to correct the problem. Or these are patients that have had an amputation and have phantom pain, for example. This is not something that you have a surgical procedure that will fix it. So if there is a surgical option, that will be the first choice. Try to fix it surgically. When surgery is not an option, then we will go to this. And I say that this is the last resource, mainly because of cost. This is a costly device. These type of implants, usually end up costing anywhere between $20,000 and $40,000 for the whole process. So that makes it a last resource. If it was a much cheaper option, in my view, it will become, second or third choice after trying some nerve blocks, because it's minimally invasive and it can provide long-term relief without requiring our patients to go on high doses of opioid therapy.
And typically, these devices are implanted for how long do they keep it, or is there like a life for the device to be replaced?
The pulse generator or battery has an average lifespan of about 6 to 6.5 years. So what we've seen in our practice is, most people after, I would say about 80% of people after 6 years, they're okay with it and they don't need to do anything else. On patients that continue to chronically benefit from it, then they will need to have that battery replaced. Just like a pacemaker, you just replace the battery, reconnect the leads, and that's it. It's a minimally invasive surgery to replace it.
And in your experience, doctor, those patients, especially that you're trying to wean out of the opioids, in your experience, do these patients tend to actually rely also on medications, on pain management type medications in combination with the device, or would this in essence resolve the great majority of their pain?
Well, it's very difficult to generalize. When you have somebody that has been on opioids for a very long time, it might be more difficult to wean the patient off the opioids. We have seen in clinical practice that when patients obtain the adequate pain relief, you're able to successfully wean them off opioids. But I cannot tell you that every single patient will be, but most people are able to taper or at least significantly lower their regular dosing.
Yeah, and we will take that as an incredibly, incredibly important highlight, simply because you need to give that chance for that patient to get them out of the opioid for obvious reasons. There are questions that I'd like to read for you, and then we can definitely move on. Let's see. This one is from Belize, and it says, low back pain. Would low back pain cause neuralgia, or would it indicate a problem with the spinal column?
I don't really understand the question, but
either. But he is referring to the fact that they're wondering if the spinal cord issue can be other than the neuralgia. I cannot speculate as of what the question is, so I apologize.
So usually when you're diagnosing a patient with chronic regional pain syndrome, you have to rule out other causes of pain. So when a patient comes that has foot pain after foot surgery, you don't necessarily take the word for it. You don't say, oh, it was secondary to surgery. You need to look for other reasons why this patient. Sometimes the pain can very well be coming from the back. Having a large disc herniation at L5-S1 could press on the S1 nerve root and give them foot pain. So part of your job as a pain specialist is to try to rule out the cause of the patient's pain, and then you'll treat accordingly. If at the end of your workup you realize that, this is a consequence of foot surgery, then obviously you cannot blame it on the back. But many times you have problems in the spine that will give you pain in other locations of the body.
Another question is, can it be used in patients with back pain and neuropathic pain due to lumbosacral nerve root disease?
So this specific device, it's indicated for that specific localized pain that we discussed before, either the foot, the knee, the groin, the ankle, the thigh. The other type of spinal cord stimulator devices, the ones that go in the middle of the spinal cord that cover a large area, like your whole leg or your whole lower back, it's what we commonly use for those type of patients.
Well, this is it's a consumer here. She is asking, or he's asking, hello, I'm an international patient. I've had PRP injection treatment, also 3 knee procedures over 10 years. I'm having lots of nerve pain. Originally was a torn meniscus. My further care was told I would need a total knee replacement. I'm 45, and how long will it benefit me to have the knee replacement possibly? It's a convoluted question.
I can answer that. I'm not an orthopedic surgeon.
Yeah, this has to be dealt directly with your orthopedic surgeon, obviously. That has to do with either a revision of your surgery or something else. But this is more for the dorsal ganglia, root ganglia, and it has to do with the spinal column. But we could definitely help you out, Jermaine, if you call us. Later on, I will share our phone number and email, and that way we can put you with the right specialist, okay? So Ana Salas from Costa Rica is wondering, if a patient already had surgery but still in pain at the hip or neck, does this device work? Does medical insurance cover the device?
So short answer is yes. If we determine that surgery was the cause of the patient's symptoms, this should help. Now, I have to mention that when we do consider these implants, it's a 2-step process. So the first step is to do a trial period. So we will place a lead on the patient and send them home with this wire coming out of their back connected to an outside machine. And the patient is going to try it at home for about 1 week. And during that week, the patient is going to determine if this is helpful or not, and if it's resolving the pain. And then once the patient says, yes, I was pain-free, while the device was on, then we move to implant. So nobody will be implanted without a trial. And yes, it's covered by most insurances.
Most insurance,
but not, it will have to be individually researched with each particular insurance.
Yeah, and Anna, I can also shed some light on that, and it has to do with, you're absolutely right, Dr. Lustgarten, not every insurance covers it. It has to be hand in hand with an increased evidence base that the patient has not necessarily improved from other types of treatment in order for the insurance to consider it. So medical necessity is incredibly, incredibly important for the doctor to justify the reasons why this device is required. Great questions. Interesting approach to pain management, Doctor. We are so fortunate to have you in M&I, and time is running out on us, but I wanted to thank you on behalf of our entire team at Baptist International for for accepting our invitation and for your presentation and for everything that you're doing in MNI. And to all of you, if you have additional questions for Dr. Lustgarten about today's presentation, feel free to email them to us at BHIWebinars@baptisthealth.net, BHIWebinars@baptisthealth.net. We'll make sure to forward those questions to Dr. Lustgarten for him to elaborate. And if any of you require any assistance in regards to pain management, please do not hesitate to contact our department. We will be more than happy to set you up in an appointment. We know how difficult it is to deal with pain. So to all of you, we look forward to seeing you at our next neuroscience lecture series that is scheduled for January 25th, 2023. In the meanwhile, thank you once again and have a great afternoon. Thank you, Dr. Lustgarten. What a pleasure.
Thank you for having me. Thank you very much for having me.